So electroconvulsive therapy, it's not something new, recent, like that's happening in the past 100 years. The concept has been there even a long time ago. So if you could look into the history of this concept, Roman emperor, it seems, had headache, and he was recommended electric eel therapy in AD 47. And then in 16th century, Ethiopians were using electric fish to treat psychosis. And then the first case report from our end, the Dr. Kinnear in 1727, he wrote a case report of 19-year-old catatonic depression. He used camphor to treat that. So camphor basically induces convulsion. So there is, um, so it's a convulsive therapy again. So next, in the early part of last century, they thought that during the cholera epidemic, psychiatric patients who were dehydrated, and because of severe dehydration, some of them developed convulsions. So the patients who developed convulsions, it seems, their psychosis got better. So they started thinking that patients with convulsive disorder like epilepsy, they cannot have mental illness because the convulsions treat the mental illness. So they were thinking that both were kind of mutually exclusive diseases, meaning schizophrenia and seizure disorder. There are a lot of papers that written in the early part of last century about this. And then in 1927, Dr. Sakil, he's the first doctor. He come up with this insulin coma therapy, by which what he did is he would give a slowly increasing dose of insulin. He will keep the patient in a semi-conscious state until they develop convulsions. So once they develop convulsions, he will stop the insulin, and then he would give the glucagon to reverse the low glucose level. So because of convulsions, patients were improving. The problem with this insulin coma therapy is because the blood sugar drops so low, patient can develop cardiorespiratory arrest and die. So a lot of deaths happen. So that insulin coma therapy was not that popular. So in 1934, Dr. Meduna, he introduced IV metrazole to induce convulsions, and he also uses camphor, like the previous doctor in 1727, who used camphor to treat catatonic depression. Dr. Meduna as well used camphor inhalation to induce convulsions, and patients did get better. But then the problem, it's very scary for patients when they develop convulsion. They just get an IV injection and then they throw convulsion. And meanwhile, there was some research going on in Europe, in Italy. Two doctors, they were doing animal experiments, like how we have now phase 1 trial. You do the animal study first. It's kind of similar to that, we can say. They were doing some experiments in hogs in a slaughter home to see how much electricity needed to induce convulsions. And they come up with some kind of a machine, and then they did the first ECT by using that machine in a patient, and it was very successful. I think it was 1936. That was the very first ECT that was given, and that's the one we are having. Similar, I mean, it progressed to the current status right now. The machine, there a lot of progress in the machine, and then anesthesia came into the picture, muscle relaxant came into the picture. So in the beginning, it was just it's called direct ECT. There was no anesthesia. In 1936, there was no anesthesia. So the patients were held, and the machine was attached, and they were given a shock, and patient developed convulsions, and patient improved over a course of ECT. And then in 1950, succinylcholine was introduced. It's a muscle relaxant. So before that, you have to hold the patient. So if you don't hold the patient properly, patient can develop fractures because when they throw convulsions, it's possible they can hurt themselves. So 1950, the muscle relaxant changed that status. And then IV benzodiazepine was used to give sedation. Then they started using short-acting barbiturates. Now we are using general anesthesia. Now the procedure is done in the OR. Outside, there is a suite called OR ECT suite, like a minor procedure room, where the machine is kept and general anesthesia given, and then patient receives muscle relaxant. So patient is not aware of what's going on. Patient receives the shock, patient develops convulsions, and the convulsions can be noted in the EEG as well. So that newer machines have that option. You can attach an EEG, and you can see the convulsions happening there. And and then the patient wakes up. Patient is observed in the recovery room for a couple of hours, and then he was transferred back to inpatient. If they are outpatient, they can go home. So what I'm going to do now is I'm going to show a movie as a film clip. I'm going to show that this is how the ECT is done in those days. This is a like Hollywood version is going to be a little dramatic. And then I'm going to show how the ECT is done now. I have a clip of that as well. So let's just look at the movie clip from before. So let me just
You're going.
Can you see?
Yes.
You're able to see that, right?
Oh, okay. You get out of my way! Get out of my way, old woman! Get out of my way! Oh, I swear to God! You follow me this time! Mama! I will fucking kill you! Done it, little sister.
Doctor, you see, all my life, I have been trying to live up to my parents' sense of excellence. I mean, the sense of independent thought and spirit that built our country. And I taught these things to Frances.
Yes, Mrs. Fong.
Francis has always been a battleground, Lily.
The point is, it's your opinion Frances is getting worse every day.
Yes.
And you feel you're unable to control her any longer.
No.
Dear, remember you did sustain bodily harm.
And the only course left open to you is to commit your daughter for a period of time to a mental institution.
Alma says it's the only way she'll
Well, all seems to coincide with what Dr. Symington had to say. And I think that's all I need to know about Miss Frances Farmer.
Good. Now, perhaps you can tell us where we can find Frances.
What's she getting, anyway?
Standard series to start.
15?
Mm-hmm. Now.
So this is how ECT is done in those days. This is a dramatic version of Hollywood version. So basically, they're doing direct ECT. They are holding the patient so that patient won't fall and won't hurt herself. They're giving a bite block so that patient won't bite herself. So all those things. So now it's all changed. So I'm going to show how a ECT is done now. So let's see. I'm gonna. Okay, so let's see. Can you see that?
No,
No, you don't see?
there is a sound, but no, nothing.
No,
We don't
no
see
video,
anything.
no video. So let me. I have to, I think, share this. Yes. How about now? Can you see? Can you see this? No.
I think you may have selected the wrong window for sharing. It seems like you're sharing your files app instead of the video.
Instead of the video. Okay, so hold on 1 second. How about now?
There we go.
You see the screen now, right?
Yes.
Okay.
Electroconvulsive therapy, or ECT, is often called a treatment of last resort for patients who haven't had success with drug therapies, who have life-threatening psychiatric conditions, or who are suffering a catatonic state. ECT induces a brief seizure in a patient which resets the brain functions associated with some psychiatric disorders.
It's typically indicated for treatment-resistant psychiatric conditions, most commonly mood disorders or depression, but there are multiple types of depression, so it can also be used to treat bipolar depression.
The majority of ECT treatments are managed like outpatient procedures, and the patient is given general anesthesia.
When the patient's asleep, the stimulus is delivered, the seizure is monitored, they'll have just one seizure.
An electrical current is given to the brain, low enough not to harm the patient, but high enough to trigger a seizure. The treatment team can even touch the patient.
The thing that concerns patients the most is that they know that they will be having a seizure. They're concerned about what may be happening while they're either asleep or while they're having that seizure. And thanks to the anesthetic, it's very hard to tell. In fact, the only way you can truly tell if they're having a seizure or not is to kind of monitor the motor activity and then monitor the EEG activity.
The patient awakens soon after and is monitored for a short while like any patient who has undergone general anesthesia. Within a half hour, they'll be discharged. In some cases, a handful of ECT treatments may be all that's needed to make medication therapy work. For other patients, regular recurring ECT treatments may be needed. In Morgantown for the WVU Health Report, I'm Dr. Raleigh Sullivan.
So, so you saw the modern version of ECT. There is general anesthesia, patient is put to sleep, and patient is not aware of what's going on. So let me go back to, so patient is not aware of what's going on. Patient has a seizure. So there are two ways of monitoring seizure. So in the second recording, they showed the EEG recording, as well as they tied a blood pressure cuff to the distal part of the lower limb, and they could see the convulsion in the foot, like the convulsive movement. So that's another way of documenting seizure. You should have at least minimum a 15 to 20 seconds duration of seizure for seizure to be effective. So there is a timer as well that records the timing of the convulsion. So the newer machines have all the options. So once the procedure is done, patient is taken to the recovery room, and then The patient whom we saw in the second recording is an outpatient. He comes from home and he comes for outpatient ECT and then he goes home. So nowadays ECT can be done both outpatient as well as inpatients. Now moving on to indications. So what are some of the indications of ECT? Can anyone answer? What do you think some of the indications? The doctor in the tapes and in the second video, he gave some examples, but there are other examples too.
There's stuff like treatment-resistant depression. You can have it for like treatment-resistant manic episode and bipolar disorder, at times psychosis as well.
Right. So the thing is, you don't have to wait for treatment resistance. It could be given as a first-line treatment. If the patient agrees, if the patient gives informed consent, especially in patients with severe depression where there is severe suicidal risk is there, patient is not eating, not drinking, catatonic, and those kind of patients, we need immediate improvement because the medication is going to take at least a couple of weeks to work. So if you give ECT, you're going to see improvement within a week. In 3 to 4 sessions of ECT, you're going to see remarkable improvement, especially in catatonic patients. So you should think that it could be given as a first line as well, apart from as a last line, which the doctor was saying in the video. So major depression with psychotic features, schizophrenia, schizoaffective disorder, suicidality, treatment-resistant depression, psychosis, mania, and schizoaffective disorder. There are other indications. Status epilepticus. Status epilepticus, the patient is already throwing convulsions. All the medications have been given to stop the convulsions, but the patient continues to seize. So for these patients, it seems if you give ECT, it stops. Looks like it's kind of, reverting whatever the connections in the brain. That's one of the indications. And then Parkinson's disease, we all know Parkinson's disease causes depression. So ECT is a very good treatment for that. And it seems on Parkinson's disease on-off phenomena as well could be tried with ECT. The next indication is intractable OCD, which is, OCD comes under anxiety disorders. Anxiety disorders in general, they do not respond to electroconvulsive therapy. So intractable OCD, you can try. We had a patient here, he was referred to us, not responding to medications. He had obsessive compulsive disorder. He was a young male. We tried ECT, but ECT did not help. So we referred back to his psychiatrist, telling them they have to find some combinations of medications to see, the plus perhaps some behavioral therapy for his OCD. He did not improve, but is one of the indications. There are case reports of improvement of intractable OCD. The last three things, they're all this NMS, delirium, hypopituitarism. They're all a differential diagnosis of catatonia. Because we don't give neuroleptic malignant syndrome, ECT, but delirium, we do not, unless the underlying problem is catatonia. Catatonia can give delirium. Then you can treat with ECT. Hypopituitarism is a differential diagnosis, but again for depression. So I would look for underlying, the disorder to indicate ECT in the last 3 indications. Moving on, conditions that's not going to be effective with ECT. Personality disorders, they're not going to improve. If they have secondary depression, the depression can improve, but not the personality disorder itself. And then somatization disorder. If the primary problem is somatization disorder, it's not going to improve. But there are certain cultures, patients, if they are depressed, they're going to, complain a lot of somatic symptoms. The way of their expression is somatic symptoms. If those patients are given ECT, they're going to improve because their primary problem is depression, not somatization disorder. So if the somatization disorder is going to be the primary issue, that's not going to improve. Next, moving on. So what are the contraindications of ECT? Anybody can tell me any contraindications for ECT?
I just asked the question, but isn't if they have a mass lesion, can it be a contraindication for ECT?
Okay, so the
space occupying lesion in the brain.
Yeah, good. So the answer is
maybe like a seizure disorder.
Right, I'm coming to that as well. So there is no absolute contraindication for ECT, meaning you weigh the risk and benefit. Suppose there is a mass lesion in the brain. If that individual is severely depressed, And if you think, and the patient is suicidal, if you want to recommend ACT, you weigh the risk and benefits. If the benefits is going to outweigh the risks, you can still recommend ACT for those patients. But you're going to get a neurosurgery, a neurology consult for that patient. And if you're giving ACT, you make sure, the neurosurgery is available in case, if they need to, We had a patient referred to us. The patient had a pineal gland tumor. And also patient's psychiatric diagnosis is schizoaffective disorder. And patient was not responding to medications, and they referred to us. And we found out that they did not know, when they referred to us, they did not know the patient had a pineal gland tumor. We just did a CT scan, and we found that there was pineal gland tumor. So we got the neurosurgery consult, and the neurosurgery cleared her, and then they were available ready in case, during ECT and anything happens, any complication happens. So we explained to the family agreed, patient also agreed, and then we gave the ECT and patient improved. Nothing happened to the pineal gland tumor, so we were able to discharge patient back to their primary provider, and also with the neurosurgery, follow-up. So let me look at the relative contraindications. There are, see, myocardial infarction, less than 6 months old myocardial infarction, congestive heart failure, uncontrolled hypertension, because ECT induces changes in the blood pressure. There's going to be parasympathetic surge and sympathetic surge. And brain tumor, you mentioned, increased intracranial pressure, pheochromocytomas, carcinoid syndrome, pacemaker. See, pacemaker is not a contraindication, not an absolute contraindication. You can still try ECT on these patients. I think there is a device which covers the pacemaker area, and then you can go ahead and give ECT. So we had a patient with pacemaker too. So we got a cardiology consult, and we made sure the cardiologist was available inside the OR when we were giving ECT. Nothing happened. We were able to give the ECT, and it went very well. So what are the advantages of ECT? I just mentioned, shorter duration of action, because medication is going to take longer time. If you need immediate emergency improvement, you can go ahead and give ECT. Any other advantage you can think of? Special populations?
Pregnancy? No systemic
Yes.
side effects?
Yes, better side effect profile. Pregnancy, all the 3 trimesters of pregnancy, first, second, and third, can be recommended. And our population, geriatric population, which is our specialty, that's another group of patients who could benefit from ECT, because they're on a lot of medications. There are drug interactions, so you can recommend to our population as well. So geriatric population, pregnancy, no drug interaction, safe, better side effect profile comparing to medications. So what are the side effects you can think of? Any side effects you can tell me?
Amnesia.
Headache, correct. Amnesia, correct. Yes. Okay, this amnesia is permanent or temporary?
Usually temporary.
Correct. Yes. It's going to be anterograde or retrograde amnesia?
Could be both, but usually retrograde.
Is both, correct. And one more than the other, but eventually everything remits, so they become normal. So let's look at the side effects. So side effects of anesthesia, and then confusion, because you are inducing a seizure, right? There's going to be post-ictal confusion. Tongue bites, if you give a bite block, and you're not going to, patient should not develop tongue bites, And fractures, you should not, because you are paralyzing the patient by giving a muscle relaxant. But if some of the elderly patients, they have osteoporosis. So say in elderly patients, if there is osteoporosis, we recommend spinal x-rays before we bring the patient to ECT. We want to make sure there is no fracture already, So you have to be careful, and you have to really totally paralyze them when you are giving ECT for those patients. Memory problems, both anterograde as well as retrograde, and they are almost always reversible, and they are temporary, and they are transient. So what is the mortality rate? It's similar to general anesthesia, lesser than general anesthesia. The mortality rate is 2.4 per 100,000 procedures of ECT, whereas the mortality rate for general anesthesia doing surgical procedure is, I think, 4.6 for 100,000 procedures. So it's actually lesser than, lesser than general anesthesia doing surgical procedures. And then whatever the mortality rate is for a normal childbirth, same thing here as well. So it's a pretty safe procedure. So pre-treatment measures, which is very important, you have to get the informed consent from patients. Make sure you get the anesthesia clearance. And you need to discontinue the anticonvulsions. There was a question whether seizure disorder is an contraindication. It is not. If a seizure disorder patient has a major depression with psychotic features and severe depression and so acute suicidality, if you want to give ECT, you can. Probably you may have to adjust the dose of seizure medications. You may lower the dose, or you can just skip the dose the night before you give ECT. Or the APA textbook recommends, you can try lamotrigine instead of other anti-seizure medications for the moment. It seems it's better in terms of inducing convulsions. And you may have to give a higher power also sometimes to induce convulsions. We had a patient with a seizure disorder who was referred to us. We did not know the patient had a seizure disorder. The patient's diagnosis was schizoaffective disorder. The patient came with Depakote and Risperidol. We thought Depakote is given as a mood stabilizer because we couldn't get the clear collateral history, and it was not clear. Nobody has witnessed seizure. The family also were not sure. So what we thought is we might as well taper and stop the Depakote. We did that. Patient had a seizure. Patient was doing fine, but then patient had a grand mal seizure between seizures. So we realized the patient had a seizure disorder. So we have to get a neurology consult, and we put him back on a anticonvulsant, and then the patient needed a higher power, higher stimulus power to induce convulsions. The patient did one course of full ECT under the anticonvulsants, and then eventually we were able to discharge him. And there are some medications, lower the seizure threshold, like clozapine and Wellbutrin. In fact, they help you because you want to induce convulsions, right? These patients on medications that lower the seizure threshold. And these patients, it seems there may be late appearance of seizure, meaning there's a lag period, so don't assume the patient is not going to develop convulsion. So once you give the shock and wait, there is a little lag time, and then see the convulsion is happening before you decide that you go for a second treatment. Moving on. So method, how the electrodes are placed. So the electrodes, how the electrodes are placed is you draw a line from the tragus of the ear to outer canthus of the eye, and take a midpoint of that line, and then 1 or 2 inches above that midpoint. So basically, it's like a bitemporal, and it's usually given bilateral. There is unilateral also. The books says unilateral also works, as there are a lot of case reports, a lot of papers published that unilateral also is as effective as bilateral. But in our experience here, unilateral is not that efficacious. It causes less side effects, less amnesia, and less post-ictal confusion, but the efficacy wise, is less efficacious comparing to bilateral. So we always go for bilateral unless the patient asks for unilateral ECT, or the family requests to try unilateral first before you go for bilateral. We did try on a patient of unilateral. We went up to 6 treatments. This treatment is given 3 times a week. So we went up to 6 treatments. There was no improvement. Then we told the family and patient that there's no improvement. Can we switch to bilateral? So they agreed, and then we switched to bilateral. Patient improved, and we were able to discharge the patient. So I'm not sure about the unilateral, but there are a lot of materials written on unilateral, its efficacy and side effect profile. And then how often and how many? So I'm coming to that. So this is the picture of how the unilateral, the bilateral, and so the first on the left is the bitemporal. That's the one I mentioned, the midpoint of the line joining the tragus of the ear and outer canthus of the eye. And then 1 to 2 inches above the midpoint, that's where the electrode is placed on both sides. That is bitemporal. So you're affecting basically the temporal lobe. And if you choose unilateral, go for the right unilateral, because 90% of the individuals' dominant lobe is left side. So if you want to shock the brain, you don't want to shock the left side of the brain because that's where the language center is there. So that's why you want to choose to shock the right part of the brain, right side of the brain. So you go for right unilateral. Right unilateral is see, it's like one electrode is on the parietal lobe, the other one is on the temporal lobe. That's right unilateral. The third picture here is bifrontal. So if the patients have a lot of side effects on this bitemporal or fronto temporoparietal, you can switch them to bifrontal. Since bifrontal has less memory issues, less confusion. And but can you do as a bifrontal as a first line? No. The APA recommendation is it could be kept as a second line. So you can try bitemporal. Patient is complaining a lot of side effects. You can space out the treatment. Instead of 3 treatments, you can make it into 2 treatments. Or you can switch to bifrontal placement of electrodes. It seems bifrontal also works as bitemporal. Okay, there's another way of doing it. So moving on. So how many treatments you want to give? Major depressive disorder, 6 to 12. That's the number we have here, but you can go up to 20. We never been up to 20. In major depressive disorder patients, they invariably, most of them, 90% of the patients, they do get better by 8th treatment or 10th treatment, not even 12. I never been to 12. All of my patients did improve between 6 to 10. Manic patients 8 to 20. Schizophrenia up to 15. I've gone up to 15 in schizophrenia patients. See, catatonia is the least number of recommendations. See, 1 to 4 treatments is enough for the patient to improve. It's a dramatic improvement if you have a catatonic patient, if you try electroconvulsive therapy. Moving on. So what's the mechanism of action? How this works? Anyone want to say anything about what's the mechanism of action? Okay, let me say. So there are a lot of theories. We do not know exactly how it works, but it works. The first theory is the neurotransmitter theory, like how a medication modulates all these transmitters like dopamine, 5-hydroxytryptamine, and norepinephrine. Same thing ECT does, but it does sooner than the, medications. And then anticonvulsant theory is the dampening of the abnormal activity of the brain. That's this theory. And then the third theory is, there is a brain-derived neuroprotective factor, it seems. There is an increased expression of this factor following ECT. It seems that's the mechanism according to this, this theory. And then changes in the cerebrovascular flow of oxygen and glucose that leads to the improvement in the patients. That's a neurophysiological theory. There are many theories. These are some of the major theories behind how the ECT works. So maintenance ECT, when do you recommend maintenance ECT? Especially, in geriatric patients and patients who have severe symptoms, who have rapid relapse of symptoms, inability to tolerate medications, you can recommend the maintenance ECT. Maintenance ECT could be weekly, and then you can change to every 2 weeks, and then every month. It could be a outpatient procedure. Patient come from their home or from the nursing home, get the treatment and go back. So it's like once a month, for these patients, who have these issues, like frequent admissions. So that doesn't mean you should not continue medication. So you have to continue medications as well. But the major thing is the monthly, electroconvulsive therapy, just one treatment. And then there are a lot of negativity about ECT, a lot of myths about ECT. There was a novel in 1962, One Flew Over Cuckoo's Nest. I think it was made a movie as well. Jack Nicholson was in the movie. In that movie, it was shown that psychiatric patient is punished. They were giving ECT as punishment in that movie. So it's and then there is anti-ECT movements there talking bad about, ECT. Some of the myths about ECT. Some they think that it's a memory loss is permanent, but it's not permanent. All the studies, all the papers, all the research work shows that memory loss is not permanent. In geriatric patient, if they already have some memory problems and they develop depression, they have depression and you're treating depression, the underlying memory impairment is not going to get better. That's going to stay as it is, but it's not going to give new memory impairment. And then there is a notion that it works only for depression. Again, it's a myth. It works for schizoaffective disorder, schizophrenia. It can work for mania. So the other indications there, in catatonia. And then in the video recording, I showed that the doctor was saying kind of treatment of last resort, but it could be a first line treatment as well. It doesn't have to be the last treatment. The next is, it causes brain damage. It does not. All the research shows it doesn't cause brain damage. There is no structural or anatomical changes due to ECT. On the other hand, there is neuroplasticity because of ECT. There are papers published, neuroplasticity because of ECT, and also there is increased expression of brain-derived neuroprotective factor after ECT treatment. The last one is the barbaric treatment, because in those days it was a direct ECT. It seems very cruel by looking at it, but now it's given in a structured setting. It's given by a team of professionals. There is a psychiatrist, there is anesthetist, there is nursing staff. Patient is given anesthesia. Patient is not aware of what's happening, and then patient is after the treatment. Patient is observed in the recovery room. So it's a kind of a modern treatment. It's not barbaric as how it's picturized outside. And then something that it will change patient's personality. It's not going to change patient's personality. It's not going to be effective in personality disorder as well, as I mentioned. And then the next myth is success rate is low. No, actually, comparing to medications, success rate is high. See, the medications, they say up to 60% of the patients will improve if you give them an antidepressant. Whereas with ECT, there is the indication is the primary indication. Then there is a 90% success rate with ECT. If you take a treatment-resistant cases, there is a 60 to 70% response rate. So it's a better response rate comparing to medications. And then the next one is the earlier I heard about whether can it be an indication for seizure disorder. Cannot be given to patients with epilepsy. That's the myth. So it can be given. I shared my case experience with you. You have to adjust the dose of anti-epileptic medications, and you may have to adjust the treatment settings of the ECT in terms of how much stimulus. Probably you have to give a higher stimulus dose. And then the last myth is a permanent cure. It is not. It is not a permanent cure. It's a temporary cure. It fixes the current episode. Patient can relapse. But comparing to medications, they're going to take longer time to relapse. To prevent that, patients should be on medications. And you can recommend them, maintenance ECT to prevent that. So it's not a permanent cure. It's another treatment, another better treatment, I would say. Okay, so I think that's the last slide. Any questions?